So Jean-Pascal Machiels, I'm the head of the Department of Medical Oncology at Cliniques Universitaires Saint-Luc in Brussels, Belgium.
Okay, Jean-Pascal, you've been talking here about a multi-blocker of the ErbB family of receptors. Now, what was the context of the work that you've been looking at here in head and neck cancer?
So patients with head and neck cancer, with squamous cell carcinoma of the head and neck, will relapse and will progress after platinum therapy, so standard chemotherapy treatment, have a very poor prognosis, with a median survival of around 3 to 6 months. And we have no definite standard of care for this patient. We know that this disease is quite dependent of the EGFR, because cetuximab, a monoclonal antibody that targets the EGFR, indeed improve the survival of this patient. And so we try to improve the blockage of this receptor by Afatinib, because Afatinib is going not only to block the EGFR, but also the other member of this family, HER2, HER3 and HER4.
So could you give me the details of the study that you've conducted then?
So we took patients who progressed after platinum-based therapy, so 480 patients, and these patients were randomized between Afatinib and methotrexate. Methotrexate is a standard chemo, but we are not sure that it has a great activity in this disease, but this is the only thing we have. So patients in this trial were followed, so were put on the treatment, and these patients were followed for disease progression. And the primary endpoint of the trial was indeed the progression-free survival. And what we show is that Afatinib improved progression-free survival compared to methotrexate, and this was statistically significant.
Okay, so the basic finding was what?
So indeed we increased the median PFS with Afatinib, so we reached 2.6 months compared to 1.7 months with methotrexate, and with a significant p-value.
And apart from that, though, you did have a reduction in the risk of death.
Yes, because when you have progression-free survival, in the definition of progression-free survival, it includes not only progression but also death. But we had also, the study was also powered for overall survival, but we were not able to detect an improvement of overall survival with Afatinib compared to methotrexate. There are many reasons for that. It could be simply because Afatinib is not able to increase the survival of the patient, but also a lot of patients receive subsequent treatment after the study. It's possible that this could have influenced the result.
Now, what is it that Afatinib is doing?
So Afatinib is going to block EGFR, but also HER2 and HER4. So it means that it will give a stronger inhibition compared to EGFR monoclonal antibody.
In clinical terms, then, what is coming out of this?
So I think in this study we show that we improve modestly the progression-free survival, but we had secondary endpoint. In the secondary endpoint we had quality of life, and we show that Afatinib delay in this patient the apparition of some symptoms like pain, swallowing dysfunction. It's also a delay the deterioration of the global health status. So we can say that the patient have maybe this patient have a better life. But the main message of the trial is that in this end-stage population we are seeing some activity, and it's quite encouraging. But we need to, the challenge, if you want, is to try now to identify the patient that will really benefit from long term of this compound. Because what we are seeing is some patients with a very long-term benefit and some patients who are not benefiting, and this is really a challenge.
Now, there are always good patients and less good patients in this respect, but what are the toxicities of this agent?
So this is a class toxicity that we know with this kind of compound. It was diarrhea and rash. This occurred in 70% of the patient. It was severe in 10% of the patient. So when we compare the two treatments, chemotherapy and Afatinib, in regard of the toxicity, we saw that indeed we have less dose reduction and less treatment interruption with Afatinib compared to methotrexate. We had also less toxic death with Afatinib compared to methotrexate. So that's true that we have some side effect. We need to manage the side effect, but it looks like quite acceptable in the context.
Of course, you can get good results if you choose your patients carefully, but many of the typical patients with head and neck cancer have quite a few comorbidities, don't they?
Yeah, absolutely. Yes, so we need to treat the patient globally, so to take into account all the comorbidities. And that's true that sometimes when we are discussing with the patient in the clinic, we don't give any treatment to some patients with their very poor condition after discussion. So that's true that the patient included in the trial had quite a good performance status. It was ECOG 0 or ECOG 1.
So coming out of this then, what are the clinical bottom line messages for treating the average patient with metastatic or recurrent cancer of the head and neck, a squamous carcinoma?
I think that there are two important points. We should try to improve the overall survival of this patient, and we should also try to make their life better, so to improve their quality of life. Frequently, these patients have relapse in the head and neck area, so they have pain, swallowing dysfunction, and this is really a bad disease with many symptoms. So we need also to improve the quality of life. Oh, I touched it.
Touching the microphone and then it sounds.
Okay. Yeah.
Okay,
okay.
let's. So what I was saying, I don't know.
I just asked you about the
so
bottom line message. Did I? No.
Yeah. So I think
What was the question I put to you?
So the question was, what should we do with this patient? Why should we treat this patient?
Yeah. Okay. So what are your thoughts about the clinical application of this knowledge?
So what we try to do in this trial is to improve survival of the patient. So that's what's an important endpoint for this kind of patient. But another important endpoint is to try to make the life better of this patient, because many patients have localization, relapse in the neck with some pain, some swallowing dysfunction, and this we need to make their life better. So these are the two main goals to treat this patient.
So the brief clinical bottom line message for doctors everywhere to take home in a few seconds, what would that be?
So we detect some activity in this end-stage population with Afatinib. It's quite modest. This improves a little the quality of life by decreasing pain, but clearly we need to identify the subgroup of the patient that are really benefiting from this approach.